So I'm going to show a series of cases, however many we get through. They aren't all totally unknowns, but I think they're all interesting. So the first case is a 75-year-old male with a history of hypertension, hyperlipidemia, carotid stenosis, and coronary disease. And he presented with worsening exertional chest pain with fairly typical meds and fairly typical blood work, and a reasonably unremarkable ECG except for right bundle branch block. Now let's see, is this going to behave or not? So here is the left system. Again, the left system, and here is the right system. So you can see that there's a lesion in the mid-right that was stented, and the patient did okay. He was discharged without symptoms, typical discharge medications, but one day later he came back to the emergency department with new chest pain, first with exertional angina and then progressing to rest pain. ECG, not terribly different. You can see the troponin and the BNP. The right coronary looks okay. And then here's the left. So pull back from the LAD into the left main. Here's the circumflex coming in here. And this is what you see in the left main. So no surprise, this was probably a guiding catheter or a diagnostic dissection from the diagnostic done a couple of days before, and the IVUS picture is quite dramatic. If you've never seen what a catheter-induced dissection in the left main looks like, this is a catheter-induced dissection in the left main. He was treated fairly typically, and I'm not going to spend a lot of time, but he was stented the left main was stented with a pretty good result, okay? So that was sort of like a kind of ordinary case. This one is a little bit more challenging in terms of interpretation. Here is a patient who presented with previous stenting in the left main to LAD, and he shows up with restenosis or a new stenosis at the ostium of the circumflex, shown here and here. It was treated with the new stent as well as kissing balloon inflations. However, you look carefully, the left main no longer looks as pristine as it used to be. Little haziness in left main. So IVUS imaging was done. You can see, the previous stent, and then in the middle of the left main, you see this. So what do you think it is? This is the still frames. What is this? So that's an hematoma between the intima of the previously placed stent and the stent. So it's an intra-stent dissection with an intra-neointimal hematoma. And that just shows you that the intima is not necessarily permanently plastered against the stent, and you can disrupt it just like you cause a dissection in a non-stented artery. So this was treated with another stent, and again, another pot, and a good result. So this is a 62-year-old female with hypertension and hyperlipidemia, PCI to the LAD 15 years ago, presents to the emergency department with chest pain, this at an outside hospital, and her ECG looks, and her angiogram looks like this. Show them again. That's the left system. The left system, and a small non-dominant right. So she was sent for bypass surgery, but presented with recurrent chest pain 3 months later. And this is her angiogram. Remember what it looked like pre-bypass. I mean, this one right here is pretty dramatic. No surprise, her grafts are either atretic or closed. And then she was sent to us. Now, let me just go ahead. So here is the old stent in the LAD. Remember, this is 15 years ago. There's not much disease around it. And then we get proximal to the old stent. The LAD looks like this. And I'm going to stop it. So what's your interpretation of that proximal LAD? Remember, she had an angiogram that looked like severe, smooth, tapering, three-vessel disease, and then she was grafted, the grafts closed, she comes back, there's no evidence of SCAD on the diagnostic, or on the IVUS study, but you see this. And so what she had was diffuse three-vessel spasm that sent her to bypass surgery. And the way you know that is because you see how the media is super thick. And you'll see that as well, and the intima is also super thick, but there's no atherosclerosis. 56-year-old female, chest pain and shortness of breath for 2 days, worse for 4 hours, no risk factors, and those are her lab tests. Here's her ECG, kind of dramatic for T-wave inversion in the anterior precordial leads. And here is her. So she's got severe osteal left main disease, and her right coronary looks pretty much okay. She had failed antegrade wiring, so she was wired retrograde, and then the wire was externalized, and you can see the IVUS pullback, and she's got focal disease at the aortoosteal junction, but the left main is otherwise normal. She was treated with a cutting balloon and then drug-eluting stent implantation with a very nice result. And since my time is just about up, I'll ask you why. What did this woman have? Syphilitic aortitis. So isolated aortoosteal disease is never atherosclerotic. You should think about other causes. If you are part of the world where syphilis is still endemic, think about syphilitic aortitis, or think about Takayasu's, think about aortic root disease, and so on. So the point of these cases, and I have now a collection of about 30 of them, Ashok, you've seen others, is left main disease is one of the most variable in terms of underlying pathology, unlike the other segments of the coronary artery. And imaging helps you, not just in terms of management, but understanding the diagnosis. Thank you for your attention.